Hey everybody, it's Christy from Mentally Kills, and I'm back with another interview. Today I have Jay with me, so I'm going to bring him out to meet you.
Hello,
How are you?
I'm great. How are you?
Good. Thank you so much for coming on. I appreciate it.
Oh, no worries.
So I like to start off these interviews by giving you a couple minutes to tell us about yourself.
Sure. I was never diagnosed with anything when I was a young child, but I do recall instances as a kid when I heard voices that no one else could hear, that things weren't there. When I was 11 years old, I was admitted to the Dementia Canada Society, which is an international organization for persons who've tested within the top 2% on a standardized intelligence test. So I was a child genius, but at the time I was also diagnosed with ADHD. And so I was doing very poorly in school, which made no sense to me because I was super smart, but was just spinning my wheels constantly. And then puberty hit, and I had been bullied relentlessly in elementary school, bullied relentlessly in high school. And after high school, in 2006, when I was 20 years old, I had a major suicide attempt. I'd driven my car down the wrong side of a major highway looking for a semi. And on that particular Sunday morning, there were no semis. And the Royal Canadian Mounted Police got my car with a spike strip and arrested me and hauled me off to a psych ward where I stayed for the next 6 months. And during that 6-month stay, I was diagnosed. My primary diagnosis was type 1 bipolar disorder with schizoaffectivity, which is a diagnosis I carry to this day. And since then, I've also been diagnosed with generalized anxiety disorder and depression.
Wow, I'm sorry, I'm speechless for a second, but I think it was the strip that caught me more than anything. You said they put a strip down to.
Yeah, they put down a spike strip to burst all of my tires because they couldn't get me to pull over.
I'm sorry, that just took me completely that was out of left field for me. Um, Actually, all of it was out of left field. So first, I'm glad you're still here. Let's start there because with anybody who has suicidal ideation, it's incredibly difficult to get past that, even after the shame spiral that comes after the survival of the attempt.
Yeah.
I mean, me personally, I've been there, not the same way, of course. Two branches, same tree, so to speak. But when it comes to schizoaffective, that is something I don't really know too much about. I know the big difference, between schizophrenia and schizoaffective disorder, but I'd love if you could fill us in a little bit more what life is kind of like with symptoms of that.
Sure. So on the one hand, you've got schizophrenia, which is a disorder that's characterized by delusions and hallucinations. And on the other side, you've got bipolar disorder, which is characterized by highs and lows, the mania, the hypomania, and then the depression. And when the two of them come together, you get schizoaffectivity and schizoaffective disorder. And so it's a classic case of bipolar disorder where you have all the traditional symptoms. In the case of type 1 bipolar, you have mania and depression. In the case of type 2 bipolar disorder, you have hypomania and depression. And then, of course, with schizophrenia, you've got the delusions and hallucinations. And so in my particular case, when I become manic, which fortunately I don't do a lot of anymore because I'm on 12 different medications right now, and a few of them are fairly potent antipsychotics that keep me pretty leveled out. So I haven't actually hallucinated in about 5 years, which is rockin', because those hallucinations were never fun. I've heard some folks with schizophrenia talk about all the fun things they imagine going on, and for me that was not the case at all. I had people generally trying to kill me for most of the time. I recall during my 2006 hospitalization, I was having a period of intense delusional activity, and I remember being in a hospital surgical bed, bound at the wrists and ankles, and a nurse walking quickly up to my bed, flanked on either side by 2 security guards, and she had a syringe in her hand, and the security guards rolled me over onto my side, and she stuck the needle into my upper leg, and I knew that it was a lethal injection and that I was being executed. And I knew that they were never going to tell my mother what had happened to me, and that was it. And it certainly wasn't a lethal injection, although it did put me to sleep. But as that black circle sort of closed, I knew that was it, and I was dead. And so I guess that's the ending point of it, but that's a brief synopsis of schizoaffectivity.
I like to consider it a little bit like you are in a horror movie that you wrote, starred, and directed in,
Yeah.
just completely created on your own. But I think for me, the hardest part, because I have, I hear not voices, but I hear music. That's part of my issues that I have. But that's a pleasant one, for me.
Yeah.
Is it always at the right time? No. Is it terrible and confusing because I'm not sure if it's actually there or not? Absolutely. It makes you feel a little unhinged, but I can't imagine, a whole scenario coming and you're not sure what's real and what's not. So how do you have something that you do to kind of prove what's reality and what's not when you had those
I've got
symptoms?
a close group of friends who I can trust to tell me the truth, and I know who they are. I've got 3 roommates who I know aren't going to BS me if I ask them a direct question about something that's gone on. Although a couple of weeks ago, I just finished the last of a series of 12 electroconvulsive therapy treatments. And one of the side effects of ECT is that it causes memory loss. And what my brain does that's really fun is when I'm missing a chunk of memory, I replace it with something else, and it's generally something that didn't actually happen. So, for example, I hallucinated that I had tested positive for COVID at work, and I had very, very clearly in my memory a positive COVID test, to the point that I was in contact with my supervisor and I said, like, I've tested positive for COVID, and she said, no, you haven't. Like, we've seen the tests. You were never positive this time. Now, I've had COVID a few times already. I work as a special care aide, and so I'm constantly surrounded by it. But in this particular case, I was missing a chunk of my memory, and my brain just filled it in with a positive COVID test. And so electroconvulsive therapy, I mean, it has been a godsend for me, but it definitely does have those drawbacks.
Gotcha. And what exactly is the convulsive therapy? Is it kind of like electrical shocks?
Okay, so I'll give you a quick rundown, and I'm very good at this rundown because I've given it about 1,000 times.
You look very excited to tell me, so I
Yeah,
can tell.
it's a good one. So a long time ago, never mind how long exactly, some scientists had been studying a group of people with epilepsy and depression. And what they had concluded after a period of study was that after these folks had an epileptic seizure, their depression was lessened. And with every consecutive seizure, their depression got less and less. And so they drew a clinical conclusion that seizures of the epileptic variety reduce depression. And so they thought to themselves, well, how can we cause these seizures in people who don't have epilepsy but who are depressed? And so they tried medications that would induce seizures, and they ended up killing a lot of patients because the medications were not the right ones. And then they figured, well, why don't we hook up some electrodes to the sides of their head and electrocute their brains? And maybe that'll cause a seizure. And so they tried that, and they were successful. And so there are 2 types of electroconvulsive therapy. There's bilateral, which is where the electrodes are on either of your temples. And there's right-sided unilateral, which is with one electrode in the center of your head and the other on the right side. And so what they were doing back in the day was passing that electrical current through the patient's brain, and it would induce a seizure that would last about 1.5 minutes. Now, they didn't use any anesthetic at the time, and the seizure was incredibly painful. And because of the violence with which these people were convulsing, they would sometimes dislocate joints or break bones. And so it was a very barbaric practice, although it was clinically effective in reducing that depression. And it had fallen out of fashion in the middle of the last decade because it sounded very barbaric and it was very scary. But we found a way using a couple of drugs. One of them is remifentanil and the other is propofol, that can be given just prior to the treatment, that puts the patient to sleep and makes it such that they will have no memory of the treatment. And so modern day electroconvulsive therapy involves going to the hospital early in the morning, and an IV is started and you're put in a surgical bed. And they wheel you into the chamber that's got the Mecta Spectra 3000 ECT machine.
That sounds really fun to say.
Yeah, and so they clean off the sides of your head with alcohol swabs, and they first inject you with remifentanil, which is a very potent narcotic that gets you really, really looped. It doesn't quite put you to sleep. And then propofol, which is a very short-acting, I mean, it lasts only 5 minutes after it's injected, but it puts you completely to sleep. And so while you're asleep, the anesthesiologist continues to push the propofol to make sure you stay unconscious during the treatment. And then a psychiatrist will apply the electrodes to the sides of your head, flip the switch on the machine, and pass that current across your brain, which causes you to have a seizure. But because the remifentanil and the propofol have paralyzed you, you don't actually have the physical convulsions. Now, the side effect, though, is that because it does paralyze all your muscles, it also paralyzes your diaphragm, so you lose the ability to breathe on your own. As a result, there will be a respiratory therapist at the head of your bed with a bag valve mask over your face who's manually ventilating you while the treatment's going on, so your brain still gets oxygen. And after 5 minutes or so, the therapy is over. You wake up in the bed again having no recollection of what had happened. You spend the rest of the day pretty sleepy and dopey and not really knowing what's going on. But then I find that at the end of the day, the pocket at the back of my brain that holds my depression is a little bit less full. And they do these usually 12 treatments in a row. And I've had a total of 42 treatments over the course of my life. And I found them to be very, very effective, although they do definitely cause severe memory loss.
Very interesting. Thank you so much for explaining that. I kind of wonder how that would, it's just me thinking, yeah, because I have asthma. So for me, like I can't even be put under for surgery. So I wonder how something like that would work for someone with asthma because they're doing I'll look into it. I'm just curious for me. Now, when it comes to schizoaffective disorder, it has features of both schizophrenia and bipolar.
Yeah.
Have you noticed, because I know that you said you work a lot with people with the disorder, I believe, right, before we got into the interview.
Yeah.
Do you notice like fluctuations in symptoms, or is it kind of just, how do I want to explain
I
this better?
spend most of my time working in long-term and palliative care. So most of my patients are elderly or dying. And in the case of the palliative patients, usually in the weeks or days before their death, they'll go off their psych meds, mostly because they're usually taken orally and they've lost the ability to swallow or take in food or water.
Right.
And we don't generally do intramuscular injections of those psychiatric medications when they're nearing death. And so definitely I can tell when someone with schizophrenia or schizoaffectivity is hallucinating or is delusional. But the features of bipolar disorder will also become apparent. And then in the case of more elderly patients as they near death, a lot of them will have something that's called premortem delirium, which is a state of general hallucination and delusion that happens shortly before death. And so the person may be unconscious for days, and then in the day or two before death, they'll wake up and hallucinate before they finally go under for the last time.
Very interesting. So when it comes to, let's focus on you.
Sure.
And your disorder, because number one, that must be a very difficult job.
Yeah.
Just because there is a lot of loss around you. What do you do to kind of deal with that, let's say, burden on yourself?
I think that death is beautiful, that it's a beautiful part of life. And certainly as someone who's experienced a number of suicide attempts, some of them nearly successful, I do have a healthy respect for death. But I think because I have been so acutely suicidal in the past and have tried to take my life, that I'm in a better position psychologically to deal with folks who are nearing the end of their lives, because I've stared down death a few times. And most of what I do is counseling, really. I mean, like, my job as a care aide is to wipe people's bums and feed them their breakfast. But a lot of what I do, because I work the night shift, is, nighttime on the palliative care unit can be a very scary place for people, especially after their families have gone home for the night. And so getting to spend long hours at patients' bedsides, basically talking them through the process of their own deaths, is an activity that carries with it a great deal of reverence. And I'm a staunch atheist. I don't think there's anything waiting for them on the other side. Once you're dead, that's it. I generally don't discuss religion with my patients unless they bring it up. And then I generally also don't discuss my own opinions. I'll ask them, what do you think is going to happen, or what are you expecting, will be waiting for you? What do you want this process to look like? And if they do express a desire for some sort of religious intervention or ceremony, it's part of my role to provide that. And many times I've sat at a bedside and read scripture to my patients if that's what will bring them comfort. And so, as I had said in the beginning, death is beautiful, just as is birth. I was present at bedside when my son was born, and I've been present at bedside hundreds of times when people have passed away. And the processes are very similar. One is on the way in, one is on the way out, but I find the emotions were very much the same.
That is a very beautiful way to look at it, really. And thank you for what you do, because again, it's not an easy job. So
no, and it's one of those things that you can't take home with you.
Yeah.
You've got to leave it at the door. When you take off your scrubs at the end of the night, that's it, and you shift into daytime mode. And I don't think about my work a lot when I'm not at work. Although I am the founder of a nonprofit called the Saskatoon Cider House, which is an upstart charity that's going to construct a standalone hospice where medical assistance in dying is offered. As in Canada, it's been legal for several years under certain circumstances. But unfortunately, in Saskatoon, both our palliative care units, our 6-bed palliative care unit and our standalone hospice, are run by the Catholic Health Association. And at those Catholic facilities, they don't allow medical assistance in dying. As a result, my patients are suffering longer than they need to when they would otherwise want access MAID. And so presently in Saskatoon, the only place you can access MAID is on an oncology ward at a hospital or in your own home. And a lot of folks don't want to die in a hospital, and they don't want to die at home. And so what the Cider House will do is provide them a third option, a home-like environment where they can come in, stay for a week. We'll treat them with 5-star service. And then at the end of their time with us, a doctor or a nurse practitioner will come in and euthanize them, and they'll end their lives in our facility, and we'll take care of them throughout the entire continuum of that dying process.
That's really honorable. That's amazing. It really is. So I can't imagine not letting someone make kind of that decision, Yeah.
And I've watched far too many people suffer in the last days of their lives. I mean, with palliative care protocols, we can insert butterfly lines to give to give Versed and Dilaudid, which are a benzodiazepine and a narcotic. The Versed, calms them down, and the Dilaudid alleviates some of their pain. But because of the fact that both Versed and Dilaudid can be fatal, we're limited in the amount of these drugs that we're able to give them, because we might accidentally kill them while they're dying, which seems really ass backwards to me. I do like the MAID process where we can use a drug like propofol to end someone's life very, very quickly and painlessly.
Yeah, I think that's kind of backwards. I agree with that. For me, I'm a very emotionally charged person. I have borderline, so I feel things very deeply. And I know that part of schizoaffective is dysregulated emotions.
Right.
So when it comes to, because you're with people who are kind of on their, let's say, so to speak, on their way, to put it nicely, how does that affect them if they have this disorder? Does that happen a lot? Because I know there's also like dementia and Alzheimer's, and then you have, schizoaffective and schizophrenia. Like, how do you discern, and how do they handle emotionally all what's going on?
Every person in dying is different. If I've witnessed 1,000 deaths over the past 11 years, every single one of them has been a little bit different. And most of the patients that I deal with in my long-term care role do have dementia. whether it be Alzheimer's or vascular dementia or mixed state or Pick's disease or whatever else it is they have. And these are conditions that are, in my semi-professional opinion, are psychiatric conditions. And we need to be working a lot more with gerontological psychiatry and gerontological psychiatry to be treating the symptoms of dementia that manifest as psychosis and delusion. And we don't do a very good job of that. And one of the BS excuses for it is, drugs like risperidone or Seroquel, which are antipsychotics, very potent antipsychotics, do increase the rates of falls. And of course, when elderly people fall, they break their hips, and this is our excuse for not medicating them, which I think is pretty stupid. I think we've got other interventions we can put in place, whether it be padded fall mats beside their beds or padded hip protectors that they wear. I think we should be doing a much, much better job of intervening psychiatrically with dementia patients. Because for a lot of folks with dementia, their delusions and hallucinations are terrifying. In a long-term care home, they don't know where they are. They don't recognize it as being their home. They don't recognize any people around them, and they're very, very afraid. And we could be quite effectively alleviating that fear with medication, and we're not, because we're just afraid to medicate old people, because statistically it increases the likelihood of death. But what in the hell is the point of trying to prolong someone's life when they're living in that state of fear and paranoia? It makes no sense to me. And so there needs to be a much larger role for gerontological psychiatry in the healthcare system.
I agree with that. I agree. So let's steer it back to you a little
Sure.
bit. When it comes to your symptoms specifically, I know that you do your treatments. Is there anything that you do for yourself that helps you other than, medications or therapies or electro waves, let's say?
Yeah, I'm a very dedicated journaler. So I journal daily. I usually find time during my breaks at work to pound out a couple of pages. I've got 7 thick journals in a row that I've written over the past decade, and I continue to contribute to them daily. And so being very, very cuttingly honest with myself about how I'm feeling, I think is very important. I'll never lie to myself about my symptoms not being there. If I am having an off day or I'm feeling depressed, I don't hide that from myself anymore the way I used to. Even as late as a decade ago, I was very dishonest with myself about how I was feeling. I would be in a state of severe depression and would try to pretend like it was anything but. Or I would have severe anxiety, particularly the social anxiety. I couldn't go out in public. I was paralyzed by it, but would always try to pretend it was something else. And I've given up that act, and I've stayed a lot healthier as a result of it. My last hospitalization was 6 weeks a couple of years ago. This was right at the very beginning of the COVID epidemic. There was a care home in Regina, Saskatchewan that was undergoing a severe COVID outbreak. Every one of their residents was positive. And the company put out a request across the prairie provinces for workers to come in and work at this care home because so many of their workers had COVID and couldn't work. And I answered the call. And 24 hours later, I found myself on a long-term care unit in a care home I'd never even visited before, responsible for 82 COVID-positive residents whose names and medical histories I didn't know. And over the 20 days that I was there, we lost 42 residents. I personally zipped up 5 body bags. And the stress and horror of that caused me to fall into a very, very deep depression when I got back to Saskatoon. And I've developed some more mental health problems based on that. Post-traumatic stress disorder has been my latest diagnosis that I'm working through with a therapist. And the home that I work at in Saskatoon right now is just on the tail end of a COVID outbreak. And going to work every night and seeing that sign on the door that says this home is on a COVID outbreak
So the trigger.
is terrifying.
It's a
Quite
trigger.
honestly, like it takes guts to walk through that door after having seen what I've seen and dealt with all those people who died without their families being able to say goodbye to them.
Yeah. Somebody who suffers from PTSD myself, as a journaler, my trauma narrative really helped me. So I don't know if you're working with that with your therapist, but I always suggest that to people. Writing it out does always help.
Yeah.
But I can imagine that sign being a constant trigger, which is not helping, because you've already got the flashbacks and the symptoms of PTSD because everybody's are different. But then you're walking to work every day, and the job that you do is honorable to begin with. So it's hard, it's tough to do your job.
It's like
To
a
walk
war
through
zone at
with the
times.
sign, yes. But to walk through that door and you see that sign every day, it's like constantly, going back to that moment in time. So
yeah, and when I had been working in Regina, like I've always had struggles with alcohol. My father was a chronic alcoholic and died at the age of 52 as a result of his alcoholism. But when I was in Regina, it was different because there was a liquor store right beside the hotel the company had put me up in, and they delivered. And so every day they would bring 24 bottles of beer to me and take away my empties. And I was drinking them all after my shifts. And then eventually I was drinking before my shifts. And then eventually I was drinking on my lunch breaks. And after I had tested positive for COVID myself, I would start setting alarms to wake me up in the middle of the night to drink so that I would never have to wake up sober. And when I got back to Saskatoon, the alcoholism continued unabated. And on one particular day, I went to the emergency room with severe abdominal pain, and a CT scan and liver function test revealed that I was in stage 1 liver failure at the age of 35. And so the disease that had killed my father was now killing me. And I had a 3-year-old son at home at the time, and I knew that I couldn't let him grow up without a dad. So I quit drinking cold turkey. And the first day was manageable. The second day, the withdrawal symptoms showed up. I was shaking constantly. I couldn't hold any food down. So I went to a walk-in clinic and I said, you've got to help me. Either I'm going to a drugstore after this or I'm going to the liquor store, and it's up to you to decide which one. And they put me on some benzodiazepines to get me through the first couple of days. And I stuck with the program and attended a few AA meetings, and I've now been sober for 15 months.
Congratulations.
Thank you.
It's a big feat. People hear that and they say 15 months. It's like, 15 months is a long time.
It's an hour-to-hour struggle. Really.
It's a rest of your life struggle.
Yeah, and I don't know that the temptation will ever go away. I'm at the point now where I can go to bars with my friends and just have my Diet Cokes and be the designated driver. That wasn't always the case. So I'm getting better. But the temptation to turn back to alcohol, knowing how easily it would make my life better, better.
Right, I was going to say perceived better.
Yeah, perceived better. The temptation is always there, but I look at my son who just turned 4 and I say, Jay, you can't check out on him.
That's right. You need you.
Yeah.
You need you. Wait till he's 10. I'll be your best friend, I promise. Yeah. My son will be 10 this year, so it's good that you have that, not just your kid, but that mindset aside from your kid. Like, I know this is not actually going to make me better.
Yeah.
Because that's what's really going to help you and keep you from going back.
Yeah, and it does give me some credibility too, because I work as a motivational speaker with the Schizophrenia Society of Saskatchewan, mostly talking to high school students about my mental health and addictions issues, and being able to stand in front of a group of teenagers and say, I haven't had a drink in 15 months. There's a bit of respect that goes behind that, especially when kids are starting to get into drinking at that age. And I like to sort of prove to them that you can still be pretty cool and badass and not have to drink.
And you know what? It gives you an immense pride, I'm sure.
Yeah, for sure.
To say, hey, I could do it. You could do it too.
Yeah.
We don't need it, So that's an amazing thing that you do too. And high school is a great place to start. And I'm glad that you're talking about mental health in high schools too.
Yeah, it's so important. And it's something that was never talked about when I was in high school.
Still not.
that's the root of why I do what I do, because it's one thing for a teacher with no experience to read out of a textbook, and it's another thing for a person who stepped off a stepladder with a rope around their neck to tell that story, and being able to tell that story is pretty powerful.
It is. And again, thank you for all that you do. You just keep adding to it. It's amazing, all the stuff that you do to make sure people are aware of what is going on with mental health. Especially when you get into, nobody talks about schizoaffective. Nobody even knows what that is. They think it's schizophrenia. They think they're both the same. And that just goes to show how little education there is out there. So the fact that you're out there going, listen, and motivationally speaking, and when it comes to drug and alcohol use with mental health, that's our niche, because we don't feel understood. No one's listening.
Yeah.
No one understands, so that's really the only escape that's available.
Yeah.
And unfortunately, not everybody gets to the stage that you're at.
Not everyone does. And I think we're also still dishonest with each other about the sort of the guts and reality of mental health, and particularly mental health treatment. And I'll provide you with a personal example, is that one of the medications I'm on causes a condition called anorgasmia. So basically, like, I can't have an orgasm as a result of this med that I'm on. And so any sexual activity with my partner has to be very planned and well orchestrated, so that I'm not taking the medication 24 hours before our intercourse and blah, blah, blah. Yeah. And I'll tell that story to 16-year-olds in a high school, because you can't hide that kind of stuff from anyone. When you want to talk about what a medication is doing or what a mental health condition is doing, you've just got to be balls to the wall honest about it and not sugarcoat anything.
Absolutely. That's good. And you know what? That raw honesty is what's going to make them respect and listen.
Yeah.
Because if you go and you're talking about it, you're leaving things out, and then they find out later, you lost all your credibility. It's gone.
Totally. And kids see through bullshit really, really easily.
I was just about to say that.
My 4-year-old does.
Yeah, they do. And you know what? Just having that raw honesty in general is what gives people credibility to begin with.
Yeah.
So it's good to know that. And it's crazy that you said that, because my secondary podcast is, I did an episode on sexual dysfunction. So as soon as you said, I was like, that word's familiar. I just did an episode on that. It's a little side note. But I usually like to end these episodes by giving the floor to you for a couple minutes. But before I do, I know that you said you had a book coming out, and I want to give you the chance to tell us about it.
Cool.
So why don't you do that, and then I'll fall back and you can give your final thoughts.
Sure. So I'm writing a book called Bleeding Daylight, and I pulled the name out of Bruce Coburn's song called Lovers in a Dangerous Time. And the lyric he sings is, "Gotta kick at the darkness till it bleeds daylight." And so the full title is Bleeding Daylight, The Art of Finding Hope in Darkness. And it's a collection of 25 stories, short stories of people like me who suffer with mental illness and addictions issues. And it's brutally honest, start to finish. We leave absolutely nothing out. It's filled with profanity and innuendo. It's not a book that's appropriate for children, but there's no BS in it at all. And the stories are all really raw and honest. And that'll be coming out hopefully sometime next year.
Well, I, for one, cannot wait to pick up a copy. So make sure you send me that link. So for now, I'll drop out, and then I'll give you the floor for a minute, and then you can give your final thoughts, and I'll give mine, and we'll go from there.
Sounds good. So the most important message that I want to leave any audience with is that no matter how bad it gets, there's always hope. And no matter how deep the darkness is, there will always be light. And it's always important to know that things can get better, that things always have the ability to get better, that all hope is never lost. And no matter how much you're hurting, just keep at it, because a day will come that doesn't hurt as much as today does. I mean, never allow yourself to be tricked into believing the lie that is despair, because you can overcome. And that's the most important message I can give you. It gets better. It gets so much better. You just got to stick around.
That was beautiful. Well, thank you so much for coming on and giving us your expertise. and telling us all the things that you do, which are, I'm sure there's 7 million more that's either coming or, that you already do, just to change the world that little bit and give that hope to people. So thank you again for what you do, and thank you for your time today.
Oh, thanks. This was a lot of fun.
Thank you. All right, I'm going to give my final thought and I'll be right back with you. So, powerful words there. It just goes to show that no matter how dark things seem, that there's always sunlight. And if there is no light, be the light. You have to keep going. And sometimes that means you have to help others keep going. I've noticed sometimes with myself that by helping others and by giving them hope, it gives me hope, because it makes me feel like I'm worth something and I have value. And I think that's a lot of what people struggle with. And if there's anything to learn from this for me today, actually, I learned a lot. So I'm not even going to do one thing because there's so much that I learned. I took notes on the side. I don't know if you guys noticed or not, but I will be posting something with this too to show. It's an infographic that I made with the difference between schizoaffective and schizophrenia so that you guys know. And I will also post this wonderful person's information and book link with this video. And with that being said, make sure you grab that book because I know that I am. And this has been another Mentally Kills interview, and I will see you on the next one.